I'm also with the Atlanta VA Medical Center, and I'm a GU medical oncologist there. Of course, we see every type of cancer at our institution. I'd like to thank the program committee for this opportunity to speak to you this morning about prostate cancer in the elderly. I do have some research support with Altor Bioscience. Our educational objectives this morning are to interpret issues of prostate cancer screening specific to elderly patients and discuss the role of therapy on hormone-responsive and castration-resistant prostate cancer, and to interpret these findings of prostate cancer studies in the context of the elderly population. So the first thing we have to do, of course, is define what we mean by elderly. As I get closer to seeing that number, I pay more attention to it. Age equals 65 or older, and prostate cancer, of course, is the most common cancer we see in this age group. An overview of prostate cancer in the SEER database, the Surveillance Epidemiology and End Results database. We look at the prevalence of prostate cancer reported in 2011. There's an estimated 2,700,000 men living in the United States with prostate cancer. The good news is 98.9% of those men will be alive 5 years after their diagnosis, based on men who were diagnosed between 2004 and 2010. So this brings us to the question, is it really mandatory to diagnose prostate cancer in men over age 65? What is the purpose of a screening test? And should men over age 65 be screened for prostate cancer? And first of all, the screening test must have a clear objective, and that usually is that we want to increase survival and improve quality of life by the early detection of cancer. So if your screening test does not do that, then perhaps it should not be ordered. Our therapeutic objectives for the elderly patient should be clear, and that is we should aim to enhance or maintain quality of life, and also to prolong life and prolong independence of life. This involves a comprehensive risk assessment, a prostate cancer-specific risk assessment. We won't go into that into detail. Geriatric risk assessment, as Dr. Balducci mentioned last evening, assessment of risk of therapeutic intervention, and then asking the question, do the potential benefits of therapeutic intervention outweigh the potential risks? So what are some of the age-related considerations that we have? So we need to determine whether the patient has, of course, capacity for decision-making. What are the patient's goals and values? And this becomes a little tricky sometimes because the patient does not necessarily know anything about prostate cancer or anything about cancer, other than some interaction they may have had with a friend or loved one who had cancer, and that event or that experience that may have been a negative experience may influence them unduly as to their own decision making. And so we must first educate the patient about cancer and prostate cancer, and then try and incorporate their feelings and concerns as we make these treatment decisions. We need to, of course, establish the life expectancy for the patient, evaluate their comorbidities, look at some geriatric syndromes, again, as was described last evening, consider their socioeconomic status, and determine whether or not they have a caregiver. This is an important variable. Some of the common geriatric syndromes that need to be documented include decreased visual and auditory capacity, whether they have evidence of delirium, dementia. This is delirium ongoing, of course, not transient. Dementia, depression, falls, functional dependency, impaired sexual function, nutritional deficiencies, polypharmacy, and restricted mobility. All of these need to be assessed. And then we ask, what are the potential complications of therapy? Can the patient tolerate the treatment? And PSA screening might appear to be a relatively complication-free intervention. However, there's this entity known as PSA anxiety, which is quite real and quite distressing to men. And if we order a test inappropriately, we now have a patient who has an elevated PSA who will be distressed for the rest of their life as to the significance of that test value. We have active surveillance that we can utilize, and then we have surgery with curative intent and the risks associated with that, particularly incontinence, and sexual impairment of sexual function. Incontinence may be to the extreme that patients may not be able to continue independence because they can no longer work, because they cannot stop having to change their undergarments because of uncontrolled urinary flow. Radiation, of course, can be associated with cystitis and proctitis, things of that nature. The side effects of hormonal therapy we'll mention a little bit more in detail a bit later. Of course, the hot flashes in particular we'll discuss. Other things such as muscle wasting, bone health, and even mental function, cognitive function may be affected by chronic hormonal deprivation. We can talk briefly about the impact of targeted therapies as well as chemotherapy in the treatment of prostate cancer. So screening for prostate cancer in the elderly. This is a study by Drazer and colleagues where they looked simply at who was screened for prostate cancer and at what age. And so they looked at men starting at age 40 to over age 85, and they simply looked at who was being screened, who had a PSA screening test ordered. And they did this in 5-year increments and found that the peak age for screening for prostate cancer was now in the 65 to 70-year age range. And they asked the question, is this the most appropriate age range? Is this a patient population that is most likely to benefit from PSA screening? And they went a little bit further. I know this is a difficult slide to read, but what it shows, basically, they look at PSA screening by age group in 5-year increments starting at age 70, then 75, 80, and above. And they also looked at if the patient were screened for PSA, what was their life expectancy in each one of these age groups. Was the life expectancy high? Was the life expectancy intermediate? Or was the life expectancy low? And they defined this in terms of a 5-year projected mortality. If this were less than 15%, then the patient was expected to have a high life expectancy. If the projected 5-year mortality was between 16 and 47%, this was considered to be intermediate life expectancy. And if the patient's 5-year projected mortality were 48% or higher, this was considered to be low life expectancy. And then within each of these 5-year increments, they looked at the prevalence of screening for these patients. And what they found, I can't even read my own slide very clearly, but what they found was 47% of the patients with high life expectancy were screened, whereas 39% of the patients with intermediate life expectancy were screened, and approximately 31% of patients with poor life expectancy were screened, which means that one could argue a good 1/3 of the patients who were screened for prostate cancer, probably more, did not need to be screened because it was very unlikely that they would die of prostate cancer. Now, taking this one step further, different study. This was a study of veterans now who were screened with PSA screening. And the question was, do veterans age 65 or older need to be screened? And indeed, what steps follow after a PSA test has been ordered? Are these patients treated for prostate cancer? Are they diagnosed with prostate cancer? And are they treated for prostate cancer? So the background for this particular study by Walter and colleagues was looking at the value of PSA screening in men ages 65 or older. And the controversy, of course, is the benefit of this has not been established. So this was a longitudinal cohort study in the National VA healthcare system. The study objective was to look at 5-year downstream outcomes. Did the patient get diagnosed, to where they treated, and so forth, and what was the impact of that treatment? The primary endpoint was prostate biopsy after PSA screening. This was a study that looked at U.S. military veterans age 65 or older who had a PSA test that was greater than 4. They looked at patients in 2003, and in order to be included in the study, they had to have 5 years of follow-up through the veteran system or through Medicare or both. And they screened over 2,905 men age 65 or older who underwent PSA screening in the VA system in 2003. Of these, 25,208 men had a PSA value that was considered abnormal, elevated greater than 4, and of these, 8,313 men actually went on to have at least one prostate biopsy. 25,000 screened with a positive value, 8,000 biopsied. 5,220 of these men were actually diagnosed with prostate cancer, and 4,284 actually were treated for prostate cancer. So this shows that even though quite frequently men 65 and older are being screened for prostate cancer, it is quite infrequent that they actually are diagnosed or treated for prostate cancer, which makes the problem even more concerning. So in summary, with respect to PSA screening, men in their 70s are nearly twice as likely to undergo PSA screening than men in their early 50s. So the age group most likely to benefit, the earlier age group, is not being screened as much as the age group that is the least likely to benefit. And 2 of 3 veterans over the age of 65 who do undergo PSA screening will never have a prostate biopsy or receive treatment for prostate cancer. So these are 2 sobering points that come from the recent literature. And what we do about that is an open question. So what should we do with respect to screening for men age 65 and older? We should use the American Cancer Society recommendation for men of all ages, and that is men without symptoms for prostate cancer who do not have a life expectancy of 10 years or more should not be tested for prostate cancer. The PSA test should not be ordered. Having said that, we need to be aware or to recall that the DRE, at least the digital rectal exam, can potentially detect rectal cancer and other things, so there's still an indication for that. However, PSA screening is still an open question. However, with this recommendation, there's a bit of concern because it says men without symptoms. So what are the signs and symptoms of prostate cancer? The problem is that patients who have early stage prostate cancer are largely asymptomatic, and so that doesn't help us very much. And what of those who do have symptoms? Men with more advanced prostate cancer may have symptoms that overlap with non-malignant conditions, such as BPH. And these symptoms include hesitancy, weak urinary stream, frequent urination, nocturia, hematuria, erectile dysfunction, bone pain in the hips, back, and ribs, and lower extremity numbness or weakness with or without loss of bladder or bowel function. So these are not specific for prostate cancer, making it difficult to apply that recommendation from the American Cancer Society to any truly beneficial extent in the men over age 65. So let's assume that the man has been diagnosed with prostate cancer, early stage prostate cancer. Should we treat that patient? Is there a role for active surveillance in men who have been diagnosed with early stage, low risk prostate cancer? So this was addressed very recently. Last month, recommendations were presented by the College of American Pathologists. They've just been published with respect to active surveillance and low-risk disease. The details are those that are largely of concern to urologists, the urologist in our group. However, there are many caveats that were included in this recommendation, and that is that sampling, submission, processing, and testing, biopsies used for prostate cancer, the tumor extent in the needle biopsies, the quality of reporting, the use of the Gleason score, other biomarkers, pathologic considerations. There are lots of things that go into having a reliable population that can undergo surveillance. So what about nutritional therapy for early stage prostate cancer? The Harvard-based Health Professionals Follow-Up Study of 4,577 men who had non-metastatic prostate cancer enrolled between 1986 and 2010, they found that men who had the highest consumption of vegetable oil had the lowest risk of metastasis and death from all causes. These men had low intake of refined carbohydrates, white bread, white rice, and desserts. They looked at 6 categories of fat: vegetable fat, polyunsaturated fat, monounsaturated fat, saturated fat, animal fat, and trans fat. And there was a direct correlation with high intake of vegetable fat and low mortality from all causes, with saturated fat, animal fat, and trans fat being quite unfavorable. What about pomegranate juice? There's some studies indicating that pomegranate juice is quite effective for PSA failure, biochemical failure. Now the patient has prostate cancer diagnosed, prostate cancer treated with surgery or radiation, and now they have biochemical failure. This evidence is not solid. It's only from a phase 2 study. However, for men who don't want to be subjected to hormonal therapy for biochemical failure, soy, lycopene, and pomegranate juice may be a helpful alternative to hormonal manipulation. Hormonal therapy for prostate cancer can be used with curative intent, with palliative intent, and we have different approaches to doing so. However, hot flashes is a common theme in this patient population, any patient treated for with hormonal therapy for prostate cancer. And the problem is we have very few studies to guide us as to how we should deal with this. It can be very distressing to the man to the point that he stops using hormonal therapy because of this. However, and the best study I've been able to find comes to us from France, 106 urology centers who enrolled patients between 2004 and 2007, and they looked at hormonal suppression with LHRH agonist. And patients were enrolled in this study if they requested treatment for their hot flashes at 6 months, or if they reported 14 or more hot flashes per week at the 6-month time point. And the primary endpoint was change in their median hot flash score. And basically they looked at 3 drugs, venlafaxine, medroxyprogesterone, and ciproterone for their treatment. And what they found in summary was that they were all effective, however that the medroxyprogesterone and the ciproterone were both higher and more effective than the venlafaxine. And the final recommendation was that we use medroxyprogesterone because it does not have an impact on prostate cancer per se and less likely to interact with other prostate cancer drug treatments. We have chemotherapy for prostate cancer. We have taxanes, of course, docetaxel, and we find that the efficacy of docetaxel is not less for men over the age of 65 than younger men. There was no difference in efficacy. However, we should consider cytokine support for these men. They have a risk of neutropenia. Cabazitaxel, no less efficacy. However, there is more toxicity, and cytokine support should definitely be used for these men. And mitoxantrone remains effective after failure of other chemotherapy agents. Newer drugs such as Sapulocil T may extend life, but this study was controversial because in the control arm, this is an immune therapy, a cancer vaccine, the control arm of that study, the men died at a much higher rate than previously reported in previous studies. It's also cumbersome to give in the VA setting because you have to harvest the patient's immune cells, you have to activate them and reinfuse them. Finally, radon 223 also has been shown to extend life for people who have bone-predominant disease. An improvement in quality of life based on their functional assessment of cancer therapy, the FACT-P score, if they have bone-predominant disease and an adequate hematologic profile. Be aware, of course, of specific cancer syndromes, bone metastases with treatment with zoledronic acid and denosumab, spinal cord compression, surgical intervention followed by radiation is important as our standard, and obstructive uropathy can be quite problematic with the need for chronic Foley or external drainage of stents and so forth. So in summary, men ages 65 or older who are fit should be treated similarly to young men with prostate cancer. Do not order a PSA screening test for men who are 65 or older who do not have symptoms of prostate cancer unless they have a life expectancy that is at least 10 years or more. And do not order PSA for any prostate cancer patient or any other test if you don't plan to use the results. Encourage your patients to eat a high diet in vegetable fats and low in animal fats and refined carbohydrates, and document impaired male sexual function, since this frequently has a significant negative impact on quality of life, and there are some things that we can do to assist in this matter. So I thank you for your attention, and we'll have questions later.